Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friend. Welcome back to this week's episode of the Healing Pain Podcast. On today's episode, we're discussing the application of the movement system in physical therapy and pain management. Human movement can be defined as a complex behavior that occurs within a specific context and is influenced by social, environmental, as well as personal factors. The movement system is the integration of multiple body systems that generate and maintain movement and human function. The concept of the movement system and movement impairments was pioneered by today's guest, Dr. Shirley Sahrmann. Shirley is a fellow of the American Physical Therapy Association and has had a worldwide influence on the practice of physical therapy through her seminal contributions to the approach to diagnosis and intervention. She has led the charge to define movement and the movement system as the core focus of the physical therapy profession, and she was the first to classify movement impairments into diagnostic categories. Today's episode on the movement system has application to musculoskeletal pain, neurologic conditions, integrative healthcare, lifestyle medicine, and for the management of chronic disease. Okay, without further ado, let's begin and let's learn all about the movement system with Dr. Shirley Sahrmann. Hi there, Shirley. Welcome to this week's episode of the Healing Pain Podcast. It's great to have you here.
Hi, Joe. Thank you. I'm very pleased that I have this opportunity to talk with you. Yes.
I'm excited and in many ways honored to speak with you about movement, about being a physical therapist, and about the movement system. Early on in my career, I took your courses and they definitely helped shape the therapist I am today and helped shape a lot of the ideas about really the human body and how we can improve both structure and function. And of course, improve movement and improve disability in people. We're going to talk about the movement system today, right?
Good.
Tell me how this conceptualization of the movement system first started for you.
Well, not calling it a system, but the movement started way back in 1980 before you were born.
No, that's not. I was born in 1973, but I appreciate that I look younger.
And actually, at the time, I was running for the APTA board of directors, and it was just so obvious to me in everything I did. And I started with the polio patient, progressed to the neurological patient, and then inadvertently to the musculoskeletal patient, that what we were all about was movement. And not only did we identify how it was problematic, but we also used it to treat patients. And then I was greatly influenced by Steve Rose, who unfortunately had an untimely death, but he was a very prescient individual and came to be director at Washington University. And he was all for both classification and for defining movement, and was very tuned in to Helen Hislop's idea of pathokinesiology. And sort of over time, rather than thinking about just pathological influences on disrupting movement, it became much more obvious how movement induces pathology. And I think that will be our big future role, is not just worrying about somebody has a lesion or a disease and therefore we come in and treat symptoms. And though I wasn't around for Mary McMillan, I was around shortly afterward. And I think what's changed so substantially, Joe, is that physical therapy was all about treating symptoms, and then the condition would heal, and then the person could get on and carry on forever. Well, what do we know? The conditions reoccur. And that what we know now with almost every medical condition is chronic. And yet, in some ways, we're still operating like they're acute problems. You get 6 visits, never to be seen again. Mm-hmm. So, and then the part of my career after I got my PhD, and while getting my PhD, I was in the Department of Neurology. And it became so clear that when you're in a department like that, that's well defined, that being responsible for a system of the body is the way the practitioner has respect. I think we're handicapped by being therapists who have started their life with the physician figuring out what the problem is, telling us what it is, and in my day, actually telling us what to do, except for the neurological patient, which is why I like treating them, because nobody could tell me what to do because they didn't know, and in many ways, they didn't care. It also was my insight into the label the physician puts on it is not a label that's useful to me at all. Just saying somebody was hemiplegic, I was pretty able to figure that out by myself. So putting all that together over the years and working with some very, very super fine people at Washington University, we came up with the idea that it isn't just movement. In fact, all of us in the world of physical therapy would carve out a silo: musculoskeletal, neurological, cardiopulmonary. And believe it or not, most of musculoskeletal treatment was stretching and strengthening. And I don't know whether it was in part because I spent a long time in the nervous system, in fact, getting my PhD in neurobiology. I was going to solve the problems of spasticity, which is probably why I do musculoskeletal, because that has not worked out well. That the nervous system played a big role in musculoskeletal disorders. In fact, a really big role. So that meant that we really need to worry about the systems. We need to worry about the biomechanics. We need to know about the bioenergetics, and we need to know about the biocontrol. And importantly, we need to define a system of the body about which we were an expert. And I think that, to me, is the real key, is that if we're just people who deliver services for some region of the body after the physician figures out what's wrong, we're shortchanging our contributions to the health of society. So that, to me, is the really big aspect of why the movement system is so important. It's a physiological system of the body. And I know there's some pushback because it's not a musculoskeletal system. It's not just the nervous system, a basic physiological system, but neither is the immune system. It's a system of systems, just like the movement system, the metabolic system. And if you want to talk about important systems, you can't get any more important than the immune system, because almost every condition that people have today seems to be somehow related to the immune system. So it made sense to me that as practitioners, we should be identified with a body system so that we have recognition like other respected healthcare practitioners, and we should spell out clearly where our expertise is. And the other thing I like about it is there's probably no system that runs the gamut of the body, maybe the immune system, like from where their synaptic transmitter is flowing, ions are going through membranes, whether you can move one part of your body, your whole body, or out in the environment. It runs through all levels of the body. So nothing's out of contention for our attention in research or practice. And it's all there. And what could be more important than moving?
You've brought a lot of history into the conversation if I start to read into that, because, you know, if we go back into our history as physical therapists, starting out really as techs, quote unquote, potentially under a physician, and the physician prescribed what we were to do, right? Yep. So we're using an intervention, so to speak, and we delivered the intervention. The doctor had control kind of over what we did or for how long we did it. And then, you know, then that was it. It was wrapped up. It was gone, right? Mm-hmm. But what you're really saying, and I do really appreciate this part of it, is that a neurologist, for example, is an expert in the nervous system.
Correct.
Right? An endocrinologist is an expert in endocrinology, where physical therapists, you're saying, should be the experts in the movement system.
Exactly right.
Yeah.
It's that easy. You got it.
It's that easy. Yeah.
It is that easy. It is that easy. So what is the movement system? That's the other part of it.
Right. So break down, because I know you have conceptual models of this, break down the components of the movement system for us. Because the truth is, and you know this, Shirley, is that the movement system is not something that they're talking about or necessarily educating about in medical school, right? They're looking at neurology, orthopedics, endocrinology, pediatrics, but...
Well, why aren't they? I mean, they weren't looking at the immune system either, and they weren't looking at the metabolic system if you go back far enough. They didn't know about it either. But they also don't look at a lot of things the dentist does. I mean, because they look at what they need to do. Would they like to look at what we're doing? Absolutely. Mm-hmm. I think that's it's our responsibility to ferret out and to demonstrate to them how important it is. I think one of the things we suffer from so dramatically is a lack of respect for how complex exercise and movement is. I mean, I had, believe it or not, Joe, I had referrals for shoulder pain problems where they said nothing for the scapula, just the rotator cuff. I didn't want to break it out and say, I think it's on the scapula for you and mess you all up. But I mean, there is a growing interest in the physician community for understanding better what we do, because I mean, particularly the people that Paula Ludwig works, that orthopedic surgeon says, we need the physical therapist to give us some insights, actually a movement diagnosis, because there is no such thing as just a shoulder impingement. Mm-hmm. So they're waiting on the brink. It's our responsibility to bring that information to them, not how else are they going to know it? You know, the big thing that's different between ourselves and an orthopedic surgeon is one orthopedic surgeon can look at the distal end of the femur and replace the knee, and another orthopedic surgeon can look at the proximal end of the femur and replace the hip, and not the two meet too carefully. I mean, I've seen mess ups from that. So what is it that we do? We look at the whole picture. How does the whole body impact that joint? How is that joint impacted by the whole body? Mm-hmm. So they've got enough to do. I mean, they can handle it with one MRI. We've got to handle it by looking at the whole system. So I'm not put off by the fact that they don't know what we're going to do, but I know they're smart and they can learn. Yeah. And they will be willing to learn once we make a case that that's what we're doing. And these days, more so than in the past. I mean, how much anatomy do medical students take now? There's the lower limb and here's the upper limb. Mm-hmm.
Yeah, I've even heard, schools getting rid of things like gross anatomy and things like that, which I think is
absolutely.
Personally, I think is
what's on the inside. You personally think what?
I think that's wrong. I think all health professionals probably could dive into gross anatomy and benefit from it in some way. Obviously, PTs need it. We should stay with that.
Of course, that's our lifeblood. Even when I was in school, there was this shift from so much. I mean, before, physician practice was anatomically locations. Mm-hmm. And so they were switching to more biochemical problems way back then in the 1950s. And now, of course, it's who cares about anything that's as big as a cell? I mean, but they've got their own thing. Joe, I even think about how sad it is for a physician who's a general practitioner, an internist, because there is so much to know. Just like I was saying before, one guy, if I want a knee replaced, I want to go to that one guy, but I'm not sure I want to find out whether that knee should be replaced by going to that one guy. My uncle got a new knee for spinal stenosis. So I know what that's about. I think so anyway, I'm not put off by the fact that physicians don't know. It's my responsibility to make a case so that they want to know.
So what are the parts of the movement system as you have outlined it?
Well, the major components are obviously the musculoskeletal system, because that's the effector, produces the movement. The nervous system, which is the regulator of the system. And in fact, that takes care of the the psychosocial aspects too, because you can't have psychosocial anything without the nervous system. And then I always think about the endocrine, cardiovascular, pulmonary systems as the support systems for that system. In other words, they don't produce movement, but they keep those other systems viable. And of course, they're affected by movement. Now, you can bring in anything you want to bring in. You can bring in the GI tract, you can bring in the GU tract, I think, and that's all well and good, but those are going to be less influential kinds of impacts on movement than these main systems. But I'm open to anything, whatever cause or or part that people want to bring into it, I'm all for it.
Right. So it's how the other systems of the body can be brought in to impact basically the movement system, so to speak.
Yeah, and to influence movement. And I think we don't want to confine ourselves to just movement, because we need to take care of the components that produce movement.
Right. So meaning if you eat a really poor diet, obviously that could be considered the gastrointestinal system.
Right.
But at the end of the day, the three key components are the neuromusculoskeletal system and how those kind of interact together.
Yeah, exactly.
And the psychosocial, or the biopsychosocial, or I should say the psychosocial, which is so prevalent nowadays, a lot of noise around that.
Right.
You have nervous system in there, so it's in there.
Exactly.
Right. So things like, even if we just stretch a little, because people are, really starting to venture out into lots of different interesting areas. Our profession's huge.
Sure.
Depression, which is a mental health condition, right, would be embedded in the nervous system, let's say.
Sure.
In that component of your model.
Yeah, and there's a lot of people that say if they were more physically active, they wouldn't be so depressed.
That's right. We now know that exercise can have an equal potency to cognitive behavioral therapy or antidepressant medication for those with mild to moderate depression.
Yeah, I mean, to me, why we should be all over it is exercise plays a role whether you have cancer or you have dementia.
Mm-hmm.
I mean, it runs the gamut, and yet, sadly, in my mind, I don't think it's just in my mind, we are not looked at as exercise experts.
Mm-mm.
I know.
Not so much. No.
No, and it's not going to be that I want to stand around counting to 10 for somebody, but I think I want to be the one that says, this is what you need to do. What you're doing matches with what your structural variations are. You're doing the right way. You're going to make a change in your life. Come see me. Let's get it sorted out as to what would be good for you. We should be the first hand on what is that exercise program? What sports do you want to participate in? Are you suited for it or not suited for it? Yeah.
And now from here, you've then started to look at movement system impairments and syndromes.
Yeah.
Tell us about how that has started to evolve and where that work has gone.
It really all started again with Steve Rose. He came in committed to wanting to do classifications. And he kind of worked his way down to modify, basically it ended up modifying the McKinsey approach, and he called it treatment-based classification. So instead of picking out a pathoanatomical explanation like McKinsey did, he named it for treatment methods. And Tony DeLito sort of worked on that after Steve's untimely death. Well, meanwhile, I was seeing patients because of Steve. He asked me to take a look at patients with him. And I got more intrigued about how movements were inducing symptoms. And the movement looked impaired to me. It wasn't matching up to the industry standard. And so we just started then changing the movement, and then the symptoms decreased and often went away. And happily, Linda Van Dillen's done a lot of documentation of this with her research. And also the other thing that was occurring that we could observe was it wasn't just moving the back itself, for example, with lumbar spine, but moving the extremities that caused the back to move. So it became clearer and clearer that here were movements affecting the back and causing the symptoms, and we could modify them. Mm-hmm. And again, my experience in neurology was that by having a label for a condition, you were setting up pattern recognition, which is certainly the difference between a novice and an expert. Mm. And so to kind of carry that on, we just started naming the condition for the movement that induced the symptoms. And when we modified the movement, the symptoms decreased or were eliminated. So that was a pretty simplistic, non-brainy way of approaching the problem. And then we've continued to work on that. You know, I find it pretty, I'll even say awful, that all of the documents that the APT has, the requirements for graduation, are to be diagnosticians. But there's not one diagnosis that we have said you need to make, not one. And I think, how can you be a diagnostician if you don't have any diagnosis? I don't know how you can be a movement expert when nobody knows what an expert is. And Joe, you know as well as I do that the biggest, I think, undermining factor in our profession is unwarranted variation in practice. You know, you can heat somebody up, cool them down, exercise them, pray over them. It all counts. Talk to them, whatever you want to do. And it doesn't matter because there are no rules. So that's why I'm very keen about, here's the movement system, and the diagnosis should be movement system diagnosis, like the neurologist makes a nervous system diagnosis, the cardiologist makes a cardiac diagnosis, we make a movement system diagnosis. And it should be movement related, just like the others are nervous system related or cardiac related.
So then,
simple.
If I'm following you on this, so then every condition, if you will, would have impairments associated with it. So as you mentioned before, right now, the orthopedic surgeon refers a patient to me with shoulder impingement, but that's really the
shoulder
symptom.
pain, but it's even more complicated. Shoulder pain. How about that one?
Yeah, that's right. Shoulder pain. But then we do a complete, in many ways, full body examination, at least upper quarter, hopefully.
Yep.
But also looking at all the other factors in someone's life, their health, their well-being, their psychosocial factors. From that, you develop an impairment-based diagnosis. Is that correct?
Yes.
And then, in some ways, it almost sounds like the DSM-5, which is what mental health providers use. They have taken clusters of symptoms, so to speak, and then created diagnoses from them.
Yeah.
So similar to that, is that correct?
Yeah, I think so.
Now, in their world, those symptoms and clusters don't necessarily always.
The sad part. I have a dog. I think she wants to go out. She has a dog door. So the advantage we have that the DSM doesn't have is that we have kinesiology, which is really nice, because if we're going to talk about movement, there are relationships. Now, you can't take the nervous system and say a problem in this part of the brain necessarily affects the other part of the brain in a defined way. They had to take behaviors and try to put them together, and behaviors don't stay too well organized. Right. We have it much easier because we've got kinesiology, we've got MRIs that tell us about things, we've got structural variations, we've got things that tell us about muscular performance that we can observe, and movement performance. Even these days, you've got a phone that records video so you can see things. So we have it a lot easier than those poor psychiatrists.
Well, my question for you would be, is movement a behavior?
It's pretty hard to say it isn't. You don't see it. you can't see it behaving.
I 100% think movement is a behavior. It's a
physiological manifestation. Yeah.
Sure. It's a key behavior that I think actually many practitioners overlook, including mental health providers at times.
I don't doubt it. But there's also many things about behavior and mental function that we can't appreciate because that's not our area of spending years and years learning about it either.
Yeah. Although there are more and more therapists interested in things like pain psychology and mental health physical therapy that are happening around the world. So it's interesting to start to think about how the movement system could start to encompass some of those growing specialties. But as you mentioned, the nervous system is embedded in there.
Embedded, absolutely. Goes any direction you want to go in.
Any direction.
Yeah.
Why do you think that, better than I do, the powers that be, DPT programs, the APTA, why have we not got together and said, okay, let's come up with our own, DSM type manual for these types of things? I know this is your life. This is your life work, Shirley. So I know this starts to.
Joe, to me, it's very upsetting because in 2013, now we're almost going on 10 years, the APTA adopted the movement system as its identity. They had a board work group. They had a task force. They had a summit. Also, we developed, they had a call for diagnosis. 90 diagnoses were sent in. An intake exam was also developed. I have not been able to find out. I haven't pursued. Unfortunately, two things happened that I think were problematic. One, the pandemic came on. Mm-hmm. Number two is the APTA was moving into new quarters. I think the powers that be weren't as keen. And I think unfortunately, Joe, and you're part of trying to be interested in another aspect, is it's hard for people to stop what they've been doing for 100 years and look at things in a new way. Mm-hmm. And I think we're up against, it's worked for us for 100 years. It'll work for us for another 100. I don't believe that at all. I think we're in deep trouble. And I think the decrease in reimbursement is a big reflection. I know that orthopedic surgeons are replacing joints and sending patients to apps. Mm-hmm. I was with a friend paralyzed in a wheelchair from multiple sclerosis. She was referred to 2 apps for exercise. Now, if they think we're doing something so valuable, they wouldn't be using apps for treatment. They wouldn't be cutting reimbursement. People would be, and look at how long we have been out there for direct access. How much of practice is direct access? Mm-hmm. I don't think we're coming on strong, and I think we have to make a change from the way we've been viewed before.
Yeah, I mean, you and I are on the same page about that. If you listen to this podcast, I'm just getting stronger and stronger with the message. I mean, I've been like that from the beginning, but as you know, as you talk, you develop, a bolder voice and things. But I want to come back to what you said there. So the APTA's vision statement in 2013 was transforming society by optimizing movement to improve the human experience, quote unquote.
Yeah. When I first read that, I thought somebody was smoking things before it was legal.
They then went on to modify it.
Oh, they didn't modify it.
What?
It's never been modified. Well,
they had an addendum to it that their mission is building a community that advances the profession of physical therapy to improve the health of society, quote unquote.
Well, that's what the APTA is supposed to do.
Correct. Yeah.
Yeah, but physical therapy, and actually, Joe, I believe it's true, because, and that's why I'm pushing so hard on kinesio-pathology, which is how movement induces pathology. In many ways, physicians treat symptoms and consequences. We could treat cause. And I like to tell people, I really believe that if we do our job right, we will be known as the profession that slows down the onset of osteoarthritis. And believe me, you'd rather get it at 80 than at 50. And I can tell you that as a very senior citizen.
Sure. Yeah.
So, yeah, I mean, so that would, and this would be cutting down on how much intervention people have to have for things. I mean, yeah. And I think the big message is just, in fact, I always love asking my patients, who taught you to walk? And they'd say, well, nobody. And I said, that's the problem. Right. Just because you're doing doesn't mean you're doing it right.
Mm-hmm. That's funny. I never thought about it that way. Someone taught them to walk, I guess, in some way, but sometimes not. Sometimes kids just learn to walk on their own.
They just walk, you know that.
Right. Just.
I mean, I don't even have any kids, but I've observed enough that people just walk, and then the clothes they wear and the shoes they wear, the friends they see, their size, all makes a difference. If they're a big guy with long legs, they'll walk differently if they have little short friends, etc.
It's funny you say that, because I've even heard other health professionals say they don't need to go to physical therapy. They just need to move their body more.
Right. That's good, because it's a good practice. It's a good business model. They'll be right back.
There you go. Right. So I always think to myself, maybe show me who the person is and I'll let you know if they don't need to see a physical therapist, because there are a lot of people who, yes, they need to move their body more and they need to see a physical therapist to work on the impairments that they have.
You know, the perfect response is all you need to do is brush your teeth and floss them, and you won't need to see your dentist. But how many people go to a dentist twice a year? And all you do is use your teeth for speaking and eating, and you need your body for everything.
Everything.
And the other thing, Joe, is the body works to be efficient, but it's not optimal. That efficiency does not mean you're using it optimally. In fact, just the opposite for that. It's efficient for what you do, but it's a compromise for how it should function in total. So there's no way, I believe, that people don't need to see a physical therapist for their movement system examination at least once a year.
Do we have a movement system examination that we have tried to standardize, so to speak, in physical therapy?
Well, I mentioned to you the one group, one task force component developed an intake exam, and it's kind of like they're calling it a screening exam. It's not a true screening exam. I think it's better labeled an intake exam, which says you go through your basic functions, forward bending, sit to stand, walking, and you kind of pick out, is that problematic or is that not problematic? And then they would need a more detailed exam after that. Now, I've certainly been working on an exam. I would happily take anybody, even without pain, and run them through that a little exam and tell them what kind of pain they're going to get, depending upon their activities, etc. Yeah.
How do we start to bring the movement system into the community?
Well, people like you talking about it.
Yeah. Because more.
Does it make sense to you?
It makes sense to me, yes. However, I do think that, because I've read your papers, I've read the perspective paper, I've looked at the conceptual model, I do my homework before.
Thank you.
Before interviews. I've also been practicing since 1995, so I've been aware of your work and even taken some courses and things like that. And as I mentioned before, it has influenced me in some way. One of the things that, and I think this is, and as you mentioned before, this is really it's a virus in our profession, is that people see us as treating their symptoms.
Yep.
People come to us and they say, I have this pain. I have this tightness and I can't move, right?
And the doctor told me my shoulder was bad.
Right. And the doctor told me I have a bad shoulder, I have impingement, but they don't conceptualize that a system of their body that keeps them alive, that makes them human, is breaking down, so to speak. That's my personal view on it.
Well, why not?
I think it's a cultural problem, because when we say physical therapist, physical therapy, people say, oh, physical, that's like fitness. So this must be about making me stronger and flexible. And it's like, well, it is. Being strength and flexibility is a component of movement, and it is a component of the movement system. But when you see a doctoral trained licensed health provider, they're trained in a whole system of how to optimize your movement, not just the range of motion of your shoulder, so to speak.
I wish. Do you think anybody looks at us as doctors? No.
When I first started my podcasts, one of the things that I promised myself, and one of the things that I take care to, is I always introduce people, usually in their bio, as Dr. So-and-so, because yes, we are doctors.
I know we are, but I'm saying, do you think the public or other healthcare professionals looks at physical therapists as doctors?
I think they're starting to, and I think they actually see us as a threat, which is why they don't want to recognize us as doctors.
I don't believe that.
You don't believe they see us as a threat?
No.
How so?
I don't think they consider that what we do. I mean, I think they think we're medical cheerleaders.
Medical cheerleaders. Oh,
yeah.
That hurts, Shirley.
Well, I'm sorry. I mean, that's the way I started out. I think they see us as encouraging people to do their exercises, encouraging people to try to get better. I don't think they have a decent concept of how complicated exercise and movement is.
Well, that's true.
You do it, well, then how can you say they have a great concept of what we do? And unfortunately, do you teach any continuing ed programs?
I do. I teach to PTs all the time, and other health professionals. I teach in some schools as well.
And do you think that most physical therapists have a good idea of what's going on in the shoulder when there's a pain problem?
I think the professionals who come into my world are extremely curious and they are very interested in improving themselves and moving the profession forward.
That is not the point I'm making. I couldn't agree with you more. I think physical therapists are amazing people. I think they're bright, they're committed. For the most part, they're not in it to make a lot of money, or they would choose medicine, etc. But do I think they're getting an education that provides high quality kinesiology observations? No. I don't think most people even know how to assess the abdominal muscle function.
It's interesting because when I went to school, there was a lot more in the programs, and some of that has been pushed out slightly because there's so, as you know, there's just so much to learn nowadays.
I know.
So it becomes a challenge of, okay, how do I bring in topics like
pharmacology,
nutrition,
or psychology? Keep going on and on. I agree with you. I think that's why we have to decide what's our strong base and what are our extras, or what can we do post professional level, post professional entry level.
Right. So you have a base and then you grow from that base.
Exactly.
Into the other areas. Yeah.
And are we compromising our base for other things because we haven't defined ourselves well enough to know what our base is?
I think the reason, to sum up a lot of your points as far as the challenges, is I really do think, yeah, we have problems from in school. We have problems coming from.
And do you know how fast schools are growing?
Yeah, I do. I really do think the ultimate challenge, though, comes with our reimbursement system, because they would have to reimburse for something like this. There's
no question. But the reimbursement system is also predicated on how valuable do you think we are, and how valuable are we making ourselves.
That's right.
We're compromising what it is we're doing out there.
That's right. That's where I see you're really talking about kind of a ground effort to say, hey, the time has come where we deserve the respect and the acknowledgement as doctoral trained licensed health professionals with advanced skill and knowledge in the movement system.
I because I'm trying to develop criteria for what a movement expert is, I've gone through the accreditation criteria. There is not any knowledge base required. You have to know treatment techniques, but you don't have to understand what the problem is you're doing. You take courses, and then you're depending upon what somebody decides to put in those courses. And I know the people that teach and that are biomechanists in our profession are very concerned about the decreasing emphasis on the basics of biomechanics and kinesiology.
So you're saying it's not in the CAPT requirements. Is that what you're saying?
That's what I'm saying. I'm saying that you have to take it, but there's no criteria. I mean, there is no criteria for exactly what you need to know.
Right. Yeah. Well, I can definitely see your point in how a movement system and a base of impairments and something like the DSM could bring the profession together in some way.
It would help with unwarranted variability. And here's the other part. If we had diagnostic categories, then that creates efficiency and effectiveness. And what's the big push now? Productivity. You're not making so much per item, so you got to get a lot of items in. Well, they keep pushing for productivity, and what that gets to be is more who knows what, and then send them out for a general exercise program by a low-cost personnel. I mean, we're undermining ourselves by compromising what it is we're doing out there.
Shirley, if people want to continue to follow you and your work and the work you're doing around the movement system, how can they do that?
Well, the best way is to go onto the Washington University website. I don't have a website, and I don't do social media, and just keep track, and then help us promote the movement system. I think if it makes sense and people really want to, and I'll make one more point before I think pushing along to get the APTA to fulfill their requirement about the movement system and about providing diagnosis, because why do people go to a doctor to get a diagnosis or to find out what diagnosis they're working on? So to go to a physical therapist and not get any kind of label for their condition doesn't speak well. And I think that we need everybody in on this effort. And that's it. I don't have a website or any of the rest of it myself.
Well said, but we will link to that website at the university if people want to.
Washington University, St. Louis.
Yeah, Washington University, St. Louis. We'll link to that so people can find you, but they've all heard it here. If you're interested in the movement system and you think this is important for physical therapists, please make sure to share this information with your colleagues on LinkedIn, Facebook, Twitter, or Instagram. You can tag me on all those social media handles. I'll make sure to tag you back, and we can enter into a discussion on what you think about the movement system and how we can move that forward for our profession. Surely having diagnostic codes that are unique to us might improve our performance within the healthcare system. I'm Dr. Joe Tatta. It's been a pleasure being with you here today, and I'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.